Okay, good morning. We can get through the boring stuff here quick, and then we'll turn it over to Mary and Stephanie, who are talking about children and adolescents and substance use today. My name's Will Schmeckley. I'm a project coordinator at Nebraska Medical Association. I get to work with our great team to help bring these trainings out. Just our usual housekeeping thing. No disclosure of relationships to disclose. Uh, Usual funding statement, we're funded by the State Opioid Response Grant. That's a federal grant from SAMHSA that comes to us by way of Nebraska Department of Health and Human Services. Yeah, usual process for CME certificates. It still says new. I guess it's not so new anymore. Just complete a quick evaluation survey. And then the newer part is I'll email out a certificate to you within a couple of business days. So just keep an eye out for that email from me that will have your certificate after you complete that survey. And if you ever miss anything or you have any questions, I think everyone here has got my contact. So feel free to shoot me an email, give me a call. Okay, so yeah, just a reminder where we are in our current series here. We are on the second one here. So after today's training, we've got a couple left. We've got Ed doing some updates on Kratom and 7OH, and then Alex talking about collaborating with emergency departments for OUD treatment. Okay, I'm gonna stop sharing my screen here, and I'm gonna let our Echo expert panel introduce themselves. Let's see here. Todd, would you like to go first?
Good morning, Todd Stoll. I'm a psychiatrist.
Thanks. And Alex?
Morning, Alex Dwork, family physician.
Thank
Hmm.
you. I don't see John Massey on. John's our pain physician. And then I'm going to introduce Ed for you. Ed's driving. Ed's a nurse practitioner, specializes in addiction. Let's see, Stephanie, I'll let you go next.
Hey guys, Stephanie Bennington, psychiatrist over in Western Nebraska and Rapid City area. Nice to see you all this morning.
Thank you. And Mary, I will let you introduce yourself, then I will pull your slides up at the same
Okay,
time.
thanks. I'm Mary Ellis. I'm a nurse practitioner and an attorney in the state of Nebraska.
Okay, there we go. Okay, can you see that okay, Mary?
I sure can.
Okay, go for it.
All right, good morning, everybody. I'm going to just give a short overview of kids and addiction from my perspective. And then I'm going to do short case studies. And then I'm going to turn it over to Stephanie, and she's going to do some case studies as well. So just talking about youth addiction, we know that it's getting younger and younger. We encounter these problems in our everyday lives. We might get a phone call, it may be in your practice, it may be in your own home. I see it a lot in my practice of law, and I also see it in my practice of medicine. So we're trying to figure out where we're encountering it and how to get some help. All right. Will's helping me with the slides today. There's a lot of different ways to initially look for the diagnosis of addiction. There's so many kids today with consistent daily use of illicit drugs. I see it all the time. Lack of motivation. Kids aren't going to school. They're staying home. They're staying in bed. They're not talking anymore. I have many, many kids that don't want to go into a physician or to a clinic. They substitute marijuana and other drugs for their mental health. It also comes from the cultures that they live in. A lot of times, behaviors are becoming erratic. We see that a lot at school. We see it a lot in the home, not able to follow rules. They have low motivation to do things that they normally would have done before. Poor follow through in schools, getting a lot more truancies. And I know a lot of this seemed to have started back when COVID hit. Kids weren't going to school. They had online schooling or weren't even following up with that, having trouble getting them back into school, and then just getting so many days where they're home. There's definitely a lot of severe mental health concerns, which is something I'm commonly seeing at this time with a lot of suicide attempts, just really flat affect from the medications or just extreme behaviors. Kids are showing up at times and they're hiding what's going on, secrecy. And then, of course, you're seeing it just in everyday life of lack of interest in school, sports, or hobbies, where other kids are super excited about what they're doing. Okay. There's At the beginning of these cases, I do some of these things here that are listed. Other people are doing different things, so feel free later to just add what it is that helps treat these youths. What I try to do in the beginning is get an initial diagnostic interview just to kind of see what else is going on, substance use evaluations from experts around. I know there's numerous experts that can work with this, a lot more adults, but there are definitely child substance evaluators, dual diagnosis, because we've got kids with both types of problems. They've got mental health issues and also substance use. And what we want to do is treat the most serious issue first. So you'll see on my two case studies that these kids sometimes come in with many, many problems and so much trauma. So where do you want to start? That's something we have to decide. Getting kids into support groups is a great idea if you can find something that they connect with. Of course, in some of these smaller areas, we don't have a lot of groups for them to join, so we have to be super creative, whether it's a diversion group where they can exercise, or whether or not it's just something where they can talk out and not feel judged. Definitely ongoing medication management, which is what we're really focusing on, and then ongoing therapeutic services. And I would say that it's really important to have the last two working together. Okay, well, all right. Here's some of the places that I've used. I use outpatient therapy, where I have a trusted therapist I can use. There's behavioral health clinics that they can go to and get services, whether or not they have insurance or not. There's free clinics, as we know, or sliding fee scale. North Point Image has a program that seems to be working well. I'm getting pretty good criteria back on that. Boys Town has an IOP program that you have to get kids to drive to if they don't live in Omaha. It's a little bit of a distance, but what I'm finding is it's worth it. Boys Town also has a PRTF if the intensive outpatient isn't working well. CHI also has a PRTF still. CHI also has a day program. Utah Holly has a program, a little bit tough, but it seems to work for some people. One World Teen and Young Adults. Heartland Family Services has a program. Native American has Ponca Health and Wellness Services. We've got Lutheran Family Services. They definitely do sliding fee scale. Centerpoint, the kids seem to love. It's short term. And then Nova, where I've got several kids right now going through long-term services. And those kids, they have to stick it out and there's a lot of change, but they help them also graduate from high school and get into college. All
Mary,
right,
there's a
next
question.
slide.
What is
Oh, sorry.
PRTF?
Psychiatric residential treatment facilities. And I know in our state, we have at least two. And then one is Boys Town and the other one is CHI. There are times when we search outside of our state to get them into a treatment facility because it's a little bit longer term, 3 to 6 months, work on behavioral concepts with them while they're in there. We always start low, and we look at what can you do in an outpatient therapy. This is what I'm experiencing. They're doing some CBT or DBT and some motivational interviewing like they would with adults. That's basically a once a week type of therapy, trying to figure out what the motivators are, what's causing any issues that these kids are having. You're looking for somebody that works more specifically with kids, which is a different ball of wax than working with adults. Level 2, intensive outpatient therapy. Not as many services, but if you look out in different parts of the state, Lutheran Family Services is really trying to kick in. Boys Town has an awesome intensive outpatient therapy program. I believe North Point's got a really good program. So if you look around or you ever need help and I can help in any way, help you find a program, I'm more than happy to do that. The problem with the intensive outpatient is it requires commitment. Okay, so you've got 3 days a week in an outpatient setting. You do group, you do therapy settings, and then you got once a week with an individual therapist. They want you to have a sponsor. They want you to do what's called a timeline of when your addiction started to the point that you're at. For some reason, that seems to be one of the hardest things for kids to do. That a lot of times they do ongoing urinalysis to see if your levels are going down. Say, for instance, that you have, a really strong addiction to marijuana. You may come in, you're testing positive, that's okay. What they want to see is that at some point your levels start to go down, and then hopefully at some point you test negative. So, next, residential inpatient treatment. So they're not going to let you in a residential because, first of all, the cost is really, really high, and there's a great waiting list. But what they focus on is behavioral modifications. They do a lot of addiction education. They have the kids do schoolwork. They work on self-improvement and self-motivation, weekly therapy. They do your medical in there. They have a psychiatrist there. They work on a level system. I've got a kid that's been at level 1 for quite a while, but he really is doing great. He just whispers to his friends while he's there. So we're trying to get him off of level 2. I know I whispered when I was a kid to other things, but in a residential, they don't want you doing that. They also bring in families. So you're not just working with the kid, you're trying to incorporate things so when they get back out that they're going to have some changes within their home. And then, I've got kids that it feels like we've tried everything, and this is more of a court thing, but I've sat in court where all types of services were exhausted. That's the word that you'll hear is, okay, we've exhausted all other efforts, and what we have now left is detention and going to a place like Harney for care. So it's not supposed to be just a locked facility. It's supposed to be a treatment facility where they're working on why are you having these issues? But let's also work on your addiction problems while you're here. It also is a level program, a behavioral modification program, and they do work to get you back out into society without using. So if you go home for a weekend, then you're tested after that. You have a sponsor, but there is definitely typically a high level of security. What we're seeing a lot with inpatient places like Boys Town and other facilities, children's, which is now open, as you guys know. It's usually a 4 to 6 day stay in the hospital or shorter. They daily meet with a therapist who gives them worksheets and works with them, or a social worker. They have rounds with a psychiatrist. Before they leave, they put together a safety plan. It should include seeing a therapist or doing some type of drug, alcohol addiction therapy, setting up aftercare with outpatient therapy, multiple daily groups. Sometimes you can refuse to go to these groups, but it certainly helps you to move on a lot faster. They do a school evaluation in reading and math, and there is an H&P with medical doctor, which is very important because some of these kids haven't had that in a long time. All right, here's my first case study, and then I'll be handing it over to Stephanie. So I've encountered a 15-year-old male Guatemalan American young man. He has a family that does not speak English at all. They speak a mixture of Spanish and Quiche. And so that adds another layer to this case. Also, there's family members that are undocumented. So there's a number of roadblocks that occur. So this kid, he presents to us after severe intoxication to where he has passed out, lost control of his function, bowels, things like that. Blood alcohol level was really high at a 0.3. Was having suicidal ideations. He did have intent and a plan, and that was to hang himself. Mom was undocumented. Father had recently been deceased. The previous year, this young man did witness his father having committed suicide on the front porch. He had hung himself. The kid is the one that helped get him down. So he's having a ton of trauma. There is a history of abuse in this family with this young man, which was both physical and emotional. He's the oldest kid in the family. A lot of blame for things, a lot of different spiritual beliefs where you don't get help with medication. That's not going to be a good thing. This is something that you need to just pray about, and it'll improve that way. Father's addiction had been ongoing for most of this kid's life. Father also had schizophrenia, so he was most likely trying to treat some of his demons with alcohol. Mother also suffers from depression and doesn't have a lot of motivation to get help. Also, definitely, seeking out services was really hard. As this patient is the oldest of 8 siblings, he also became the caretaker in this particular case. So some of the things, beginning things, where do you start with something like this? Mom doesn't speak English. I know as providers, we try to get interpreters in, whether it's in person or whether we're using our phone or whether we've got a service out there, but we've got to connect somehow with these people and get them to get on board so that we can give them some help because they are really suffering. Okay. So looking at him individually, he has daily substance use to include alcohol, marijuana, has used benzos when he can get them. And then in his peer group, he had occasional cocaine use, which was more minimal. He takes blame for his father's death. So he's got ongoing suicidal thoughts, not ongoing suicidal attempts, but definitely difficulty with getting through his day and trying to figure out how to not feel the pain of what he's feeling. He feels like he is the caretaker for his siblings because of all the reasons we talked about, mom being undocumented, mom having low motivation, feeling like you're taking the blame for everything. And so then we start trying to get him services, get him in for evaluations. His substance evaluation definitely shows that he's got addiction issues. He's got an IQ of 67. When you see this, then you're going to have to be more creative because a lot of facilities will not take you. They just say, hey, we don't know what we can do in this situation, and our protocol is to not take somebody with a lower IQ. We did get him a therapist. He wasn't attending school on a regular basis. We had got him on probation, had people driving him to school. So also, if you're not going to school and you have a therapist that's at school, you're not connecting with your therapist. Little guy, he's a smaller guy, bullied at school when he was attending, so that was an issue we had to work with. He had another event of nearly toxic intoxication, inpatient for another 4 to 6 days. We put him on the PRTF list and fought back and forth. We got an updated psychological evaluation. Just, hey, you know what? He's Spanish speaking as primary language. Maybe we can get that IQ up a little bit. Um, he was diagnosed with major depressive disorder. You can see there impulse control. I don't really like a conduct disorder on a kid that age. And then mild intellectual disability. We were looking at what the best treatment plan was for this kid. He is in PRTF right now. Seems to be doing pretty well. If you guys have other ideas or options, it's always good to, just kind of let us know on those things. But that's that first case study. Right now, he seems pretty stable, and then we're just kind of looking at the next step. Okay, case study 2. Like I said, our kids are getting younger and younger. 12-year-old female. And we know that this problem did not start when she was 12. That is just when we intersected. She is someone that was a victim of sexual abuse at a very young age within the family, was exposed to drugs and alcohol at a very young age. It's definitely a lot of sexualized behavior, has no fear of meeting up with people or relationships. She has internet is the other thing that we talk about a lot, and how that's changed with building online relationships with each other. She tends to go towards older men because they always say, "Hey, I'll help you out. Oh, I could buy you this. Let's meet up." So it's hard in these kind of situations to talk about drugs and alcohol as being a bad thing because it's already so integrated into her life. So she was previously prescribed Adderall for focus in school, so had that diagnosis, Lexapro and Trazodone. Mom decided that maybe these medications weren't really beneficial to her, so she was weaned off of them. She's not using any medications right now other than birth control and something for migraine, which is amitriptyline. She had, when this case was brought in, she was having ongoing drug use to anything that was offered to her. Like I said, just really a lack of fear about anything, but also not a lot of information. Drugs that she states she's used have included marijuana, alcohol, methamphetamine, cocaine, PCP, mushrooms. She tells me that her use was consistent, and she's was having all sorts of behaviors that the cops were coming a lot wherever we were at, physical and verbal aggression, fights with her parents, court filing. She was cutting on herself, which was pretty consistent. She had been inpatient short term on 3 occasions. She had past suicide attempt, but most of those were cutting issues, so they may have been more self-harm. She had expulsion from school. Like I said, a lot of previous sexual assaults, ongoing nightmares from trauma. So when we were working with trying to get her some services to help her stabilize and the family stabilize, there was a lot of anger going back and forth. She would not follow whatever her parents were saying, but the parents were not always home. So say mom was gone during the day and they would say, "Hey, you need to stay home." She would take off. Of course, she didn't have any adult supervision. Dad and mom were divorced, but dad was also working. So trying to get someone else into there, like a community youth coach, which we have through probation, but they can't babysit all day. So we started with weekly outpatient therapy, trying to get her at least a better understanding of the drugs she was using and to keep her maintained. Started doing some trauma therapy. Um, Definitely found a couple of times in the beginning that she was willing to trade sex for drugs. Um, did some foster care placement, which was unsuccessful. So she did also go into PRTF, did 4 months in PRTF, seemed to help her a little bit. And after that was discharged not to home, but to a treatment foster care placement. And she's currently there. She's got family therapy going on, individual therapy. She's got trauma therapy. She's in school, but she still has a little bit of work to do. It still seems to be with relationships and trust with people that she will take anything from them. So it's just one step at a time. And we're looking at what treatment plans we can offer. And if you have anything else that you'd like to offer, then it's sitting right there. And that's my portion.
And if anybody has any questions first, for Mary, before I switch over, feel free to ask now regarding those cases. I think, was there anything in there? Okay. All right.
I've
Now,
not seen anything yet.
okay. I will pull up mine. We can always do them at the very end too. Can you guys see mine?
It looks good.
So I'm going to continue off with kind of what Mary was going through, talking a little bit more about the addiction pathway, things like that. I'm going to add on another piece that's very important, especially in the child and adolescent population, that I know Mary sees as well, both in the legal system and within the mental health system as well. And if anybody's ever been in my talks before, I spend a lot of time always adding in ADHD as a component of substance use because it has such a high prevalence. If we're treating substance use, it's really a disservice to patients to not treat ADHD as well, and especially not to screen. Anybody that comes with substance use should be screened for ADHD, regardless of age, because a lot of times your treatment is kind of right in front of you, and it's going to help you with whatever your treatment is for the substance use. It's essentially going to help you tremendously if you can actually treat the underlying issue as well. So the one statement I always say to all parents, I say to everybody, adults or children, is if we don't treat the ADHD, these kids will, and their version is going to be much riskier than ours, and that's the truth. They don't have the frontal lobe full development. They're not going to make rational decision making. Even adults don't fully do that. So asking a child and adolescent to do that is simply asking them to choose make the wrong choice. So in children and adolescents, they're not going to use substances in a vacuum. It's not that textbook picture perfect scenario that we seem to know. We know the science, we know the symptoms that we all learn about. It's not like that with children and adolescents. They're just most often they're just attempting to regulate their focus, their energy, emotions. Majority of the time, and I say majority, like I would say even 98% of the time, there is some symptoms prior of they're asking for help in some way, typically before they end up going to substances. So a little bit of the link, just to kind of put it in perspective, ADHD prevalence in society is about 5 to 11%. That is a pretty big range. We've consistently always thought it to be around 5%, but we're starting to see that prevalence may actually be higher. ADHD, if a person has ADHD, it does increase the risk of early substance use disorders, 2 to 3 times higher than the general population. And it increases risk of impulsivity and risk taking in general. And when we think about, and why do I always kind of go back to ADHD when it comes to substance use, is because they share the same pathways. ADHD is a deficiency in dopamine. It's plain and simple. That's what it is. Our stimulants and our medications that we have available, that's what it does. It increases dopamine. That is the treatment. And what is addiction? What is that pathway? It involves that dopamine pathway. It kind of feedback, the dopamine itself kind of feeds back and creates that reuse and ongoing use of the addiction itself. And so it makes sense that those two pathways would come together, and why people with substance use do have a higher risk of ADHD. So some of the consequences of ADHD, if we're not looking for this, if we're not treating it, it does increase the risk of substance misuse. Research, we have many studies to show that this has been something that we've known for quite some time, that continues to be found in it's consistent and reliable in what we see in the actual studies. It increases criminality and incarcerations. A majority of our population in general, about 25 to 30% of the incarcerated youth have ADHD. This tends to be much higher even in the adult population within prisons and jails. But just looking at it from the adolescent and the youth's portion, 25 to 30% of incarcerated youth have ADHD. You guys, this is incredibly high. And a lot of these kids are not treated. And so you have to ask the question, well, at what point could we have potentially treated to prevent these children and adolescents from actually having that outcome? Some other consequence of ADHD, it increases accidents and injuries. We're thinking like once they get their driver's license, they're more inclined to actually, lose focus and actually get into wrecks. Accident injuries with just falling. People with ADHD and children and adolescents with ADHD are more accident prone. That's a lot of a big symptom that I see with parents when they bring their kid in, is sometimes they were even seen by a neurologist before, because they're like, yeah, my kid is just always running into walls. They are just always falling no matter what I do. They climb a tree, they're just so hyper. And then no matter what, I just know they're going to fall. I know they're going to break something. This is typically what I hear. Untreated ADHD even increases suicidal behavior. There's a lot of negative feelings that they have about themselves. Kids with ADHD have a lot of empathy, and they have a lot of self-awareness. And so, and a lot of times they're not getting things done. They're not able to just create this executive functioning that they need, but they have the awareness to know what they're not doing right. And so that increases risk of suicidal behavior. And then of course, it can lead to poor academic and occupational outcomes. We see this often. We see it in adults with they're constantly losing their jobs. We see it in kids where they could be straight A students and all of a sudden they're failing everything. It just doesn't make sense. And then we say, well, you're not trying hard enough. Maybe you're lazy. Maybe you could just, if you could just do it. Yes, it would be great if they could just do it, except you need executive functioning in order to do that. And simply they don't have it. So when we think of medications for ADHD, just going to kind of bring this to the forefront here is, remember, stimulants are our best treatment that we have for treating ADHD across the board, regardless of age. It is the strongest evidence. It works really well. American Academy of Pediatrics also supports its first-line use. But just to kind of put it in perspective, I always like numbers. I always like to kind of show you why it works and the differences. So the efficacy of stimulants, and we're thinking like our methylphenidates or amphetamines are their two main groups. When they looked at a lot of the studies, and there's a lot to support that the stimulants are more effective than the non-stimulants, but the effect sizes are pretty large. And our response rate is 70 to 80%. And there's, and I can't think it off the top of my head, but there's even one study that shows that it's even 93% is the highest that I've seen. But most of the studies generally are between 70 to 80%. It's a rapid onset, same day. So one thing I always tell parents especially is, when can I expect to notice an outcome? That day. If you're not noticing that day, then we need to taper up relatively quickly, which I usually wait about anywhere from 4 to 7 days typically. Non-stimulants, we're thinking are atomoxetine, guanfacine, clonidines. For the studies that we have available, effect size is pretty moderate. Response rate is not great, 40 to 60%. And what I'm seeing actually in clinical practice, I'm not seeing 60%, to be honest with you. I'm seeing closer to 40. It's not great response rates typically. And I'm honest with parents. I'm like, this is either going to work or it's not going to work. And when it works, it really, really works for our non-stimulants. But when it doesn't work, it does not work. There's not even really a partial improvement. It just doesn't work. So I always tell other clinicians to not delay treatment, have a low threshold for actually switching over to a stimulant, because if it's going to work, you're going to see it relatively quickly within 2 to 6 weeks. If we have no effect within 2 to 6 weeks, then switching over to a stimulant should be the next choice if it hasn't already been done. And then overall, stimulants are more effective. Here's some of the data just to kind of show when we look at substance use in treating ADHD, all the data supports that it does not increase substance use risk by treating people with a stimulant. We found that it reduces the substance use, it reduces criminality. There is no increased risk overall of long-term substance use. And it actually has a possible protective effect of it doesn't potentially just bring people with ADHD down to the baseline risk of substance use risk in general. It actually can protect against it. That one is not found consistently across studies, but some of the studies do show that. And then if it actually lower rates of later substance use treatment or substance use disorder if you actually treat them with a stimulant. And so key points at the bottom, the highest risk group is untreated ADHD. And then again, evidence consistently shows that treatment improves, not worsens, the long-term outcomes. And this was another study, one of the made analysis of looking at stimulants and versus non-stimulants, and stimulants are more effective than the non-stimulants for the core ADHD symptoms, but both are superior to the placebo. And our non-stimulants, of course, have a place in medicine in general, and with anxiety, tics, sleep issues, substance use concerns, poor stimulant tolerance. And then at the bottom there, if your goal is symptom control, you guys remember stimulants are always going to work the best. If your goal is safety or tolerability, non-stimulants are great alternatives. But again, remember, these things are not equally effective. The data shows it. It's a substantial difference in efficacy. And I always kind of like to put it in perspective. I got to move my thing out of the way. There we go. When we're looking at untreated versus treated ADHD, this kind of just puts it all into perspective. I mean, what I said before, I mean, if we have untreated ADHD, it increases substance use, criminality, accidents, suicidal behavior, kind of everything that I said before. And this is for both adults and kids, but I'm looking at more from the child and adolescent population, because this is typically when these people have not had exposure to substances or have not had exposure to criminal activity just yet. Just having the ADHD diagnosis increases all of this. So if we can intervene at an earlier stage and actually treat them, you guys, this is what we're reducing the risk of. And so flipping it over onto the other side, when we treat ADHD, especially with stimulants, we're actually decreasing that substance misuse, 20 to 30% reduction, which is big. Decreasing criminality, we're decreasing the ER visits, overdoses, injuries, suicidal behavior, and it actually improves their academic performance. And overall, this is improving not only the lives of these kids, but the better long-term psychosocial outcomes as a result of actually treating them. So remember, biggest risk, no matter what, is under treatment. So when you think about for the children and adolescents that are coming into your guys' office and they actually have an active substance use, maybe or maybe not, they had an ADHD diagnosis, but right now we know an active substance use, and we found that they actually have ADHD as well. What do we do about that? So number one thing, we never want to delay ADHD treatment. I hear a lot of times, especially still today, even with the research, is we're treating one or the other, but we're never treating both. And this is when we're only treating one, you're asking this child or this adolescent to essentially find treatment for the other aspect, or do it themselves. And it's truly setting these kids and adolescents up for failure, because you can't just treat one or the other. ADHD symptoms are typically driving the substance use. So if the ADHD goes untreated, you're increasing the risk of relapse. And that's right away, right at the beginning of their substance use treatment. They're already having to get past these mountains of the higher relapse rate. So when we withhold the treatment out of fear of addiction, we are actually be increasing the very risk we're trying to prevent. So that's something I want all of us to kind of really take home. When we have that fear of the addiction, we're increasing the thing that we're trying to prevent. So the question that I get all the time is, is, should I start a stimulant? When it comes to ADHD and substance use, this is the one question I will consistently get with every consult. Every question is, should I start a stimulant? My answer is always yes, if it's done carefully. And the recommended approach, and this is kind of what I always try to keep it pretty clear, so that we have a clear path of what we could do. And it's typically go right to a long-acting formulation and go right to Vyvanse. The research shows that it's got a lower abuse potential. I would even kind of argue that Concerta potentially, it also with some of the studies, has a low abuse potential as well. It's not studied as heavily as Vyvanse is. And so really with what the research shows is Vyvanse has the lowest abuse potential, and this is the one we should typically start. Again, and I put the other extended release methylphenidate, Concerta. If somebody does not tolerate Vyvanse, low threshold, go right to Concerta as well. But typically, I kind of see the other way. Usually, they don't tolerate Concerta as much, and Vyvanse they generally tolerate better. Avoid our short-acting stimulants initially. We don't want those ups and downs and emotions and lability, and we don't want the start-stop. We don't want that rush of the medication initially. It can kind of lead to that more of that euphoria. That's what we're trying to not look for, trying to get not to induce. And then with children and adolescents, parental supervision of the medication is absolutely important. We need to give them limited quantities, which they already are pretty limited with federal regulation in general, but frequent follow-ups. I'm seeing these kids initially every week and then to every 2 weeks. That's typically what my follow-up pattern is for substance use in general, on an outpatient basis. And so, especially with kids, we want to see them as often as possible, as often as your schedule will allow. Random urine drug screens, I always put here. It's really dependent on the provider. I don't typically do them, and that's mainly because I get this rapport with patients. I get this honesty, and it's not that they're coming in and telling me they're not using. It's actually the opposite. They're telling me they're using every time. And if you're telling me they're using, why do I need to check that in a random urine drug screen? It's, I believe them. They are using. Here's a little algorithm I made, and I'll definitely make sure the slides get sent out. But this is always what I try to print out for people to kind of reference back. And if they have children, adolescents, they have ADHD, active substance use, number one thing we need to remember is not delaying that ADHD treatment. So then kind of go on to the next step is assessing the risk of misuse and diversion. That's low risk, meaning they've never misused any substances. They have a good family support. They can have that supervision. They have a stable environment. Go right to a stimulant. Long acting, you got those safeguards in place. That's a moderate risk, meaning they maybe have some past misuse. Like if a teenager was like, yeah, sometimes when I have a test, I took a couple extra doses of my stimulant when I used it. Or if they're not really using, or they have intermittent substance use. If you have any of those two in your history, I would consider that kind of moderate use. So you could have two different options here. You could do a structured stimulant trial, or you could do the non-stimulant. And the structured stimulant trial, meaning having the parental control, safeguarding the medications. If it's teenagers, I typically tell parents, get like a 5-day, usually you can do like a 3 to 5 day med box, and just putting like one pill, give them access to maybe the 3 to 5 pills, depending on age. So that if they ended up using more, they only have like 3 to 5 pills essentially, but it still lets them have some level of independence, because kids don't, especially teenagers, don't typically like to go and ask their parents. For as needed medications, I usually give them access to about 3 to 5 in a different med box, and just making sure the overall amount of medications that they have access to would not lead to them potentially being hurt if they did end up taking them all. And so just coming up with these plans in place so that both parents are in control, these teens feel like they are in control, and then we get this improvement in communication overall. And then high risk, if they have multiple substances on board, they have no parental supervision, they have a high diversion concern, telling you, I've sold them before. Who knows if I'll do them again? Then, obviously start with the non-stimulant option. And then, but have the understanding that it's okay to switch them over to a stimulant at some point if we can get them off some of those substances. If we can get them to show consistent follow-up and have them engaged in treatment, then it makes sense to eventually switch over to stimulants if we need it. So, and then I'll quickly go through. Okay, about 15 minutes. I have 2 cases to go through. This one is more straightforward. The next one is a case that I actually recently had. It's more controversial, and I kind of want to walk through what I ended up doing for this one. But this is a kid. This is one we commonly see. Our teens are. There's a lot of cannabis use. They are getting access to this even earlier and earlier. I had a 10-year-old the other day that was using cannabis. And over here in Rapid City, kind of Western Nebraska area, I'm seeing a lot of even a lot of earlier use of mushrooms. Even a lot of. I had one kid that it was about a 12-year-old actually had access to ketamine. I'm just like, how are they getting access to this? Well, they are. It's yeah, they can get access to anything if they know the right people for it. But this case, he was a 16-year-old male, ADHD, had combined type, had a daily cannabis use. The statement he always says, well, it helped me calm down and helps me sleep. Typically, when it comes to ADHD, the sleep issue is typically what they're always looking for is they cannot sleep. ADHD is often associated with that delayed sleep onset. So their melatonin isn't actually kicking in until about 2, 3 in the morning. So they're needing something for sleep. So this is pretty common to hear. But this child was failing classes, poor focus, impulsivity. They, in the past, they had been tried on methylphenidate, but then they stopped for just whatever reason. They don't. The child that was like thought that maybe his parents didn't bring him to follow up. The parents were like, well, he didn't really want to take it. So who knows why, but ultimately he didn't stay on it. He had no history of stimulant misuse or diversion. And then parental support was actually really good. And they were willing to supervise the meds. There was a lot of conflict between parents and him. He wanted to be in charge of everything. You know, a 16-year-old, he's pretty much thinks he's an adult, knows what he wants, knows what he should do. Parents are trying to have some level of involvement in their life and not knowing how to balance that. So the question is, should we start a stimulant? Yes, no, non-stimulant first. This one I made it pretty clear, specifically that no stimulant misuse or diversion, just cannabis, absolutely go right to stimulant. The answer here is it would definitely be a stimulant. And that's absolutely what I did. Let's see if I put on the next slide. Yeah, I'll tell you what stimulant I did. But for cannabis use, I put some treatment approaches that we have. First line that we have for cannabis use in adolescents and children in general is our behavioral therapy. That is essentially the treatment for it. Motivational interviewing. I kind of went through a lot of what these were in a previous lecture that I did, but just a kind of a little bit of a recap on what they are. Motivational interviewing, you're meeting them exactly where they're at. You're having those conversations. What do you like about it? What do you not like about it? You're getting them to talk about it in not a negative or positive light, just basic understanding of how they feel about it. And kind of then you can start guiding them forward. CBT for substance use, then you're understanding what the triggers are, the coping, alternative behaviors, or helping them change that behavior aspect of it, which is long-term outcome. Trying to get them to identify the trigger, identify the response, and then get them to change the behavior as a result instead of using the cannabis. And then contingency management. This one is the most evidence-based. This is the one that we typically see in the legal system and the criminal courts itself. We're looking for those essentially those little rewards for not using, the negative screen for reducing use, where we have some reward in general of saying, good job, this is great, let's keep doing this, to give them a reason to keep not using or keep having those negative urine drug screens. Then step 2, of course, as I said, I've kind of stressed before, is we're treating ADHD at the same time. We want to start the appropriate ADHD medication. Why it helps? Because we're improving their executive functioning, we're reducing the impulsivity, and we're decreasing their need to self-medicate. So this teen could not sleep no matter what. He struggled with going to sleep anytime before 2 a.m. Parents were like, oh, he's using too many video games. That's the issue. Sure, that definitely plays a part, and he struggled to pull away, but that's not the main reason why he can't sleep. That's just the thing he's using to cope while he's not able to sleep. So with this child, what I ended up doing is I started him on we went straight to Vyvanse, since he had been on Ritalin before. Obviously, it wasn't that effective if essentially he ends up not stopping it. Neither of them remember why. Clearly wasn't working, or else he would have stayed on it. So we went to Vyvanse, did well. For most kids, I usually start Vyvanse at about 10 milligrams. For him, I started at 30, which is a typical starting dose. and he did well on it. And I ended up giving him clonidine at night for sleep. And now he was going to bed at like 9 a.m. or 9 p.m. and did very, very well with it. Got him into seeing a therapist on a weekly basis. Didn't like that therapist, didn't do well. He actually had a little bit of slips with the cannabis. Started going back to using every day when we discovered that he just wasn't connecting well with that therapist. We got him over to a therapist that he connected very well. And within about 2 months, we had weaned him off completely, wasn't using. And then I just saw him recently, and it's been about 6 months since he'd used, and he'd applied for college. He was going to graduate early. He had great goals. Like it really made a difference in his outcomes. Here's some, I ended up not using any of these, but these are some non-FDA approved medications for cannabis use. And these, again, we're not using these as primary treatments. These are just adjuncts if they're needed. Some of the research and evidence is really mixed on this. N-acetylcysteine, some adolescent data showing it reduces use. I personally have not seen it. The only time I've ever actually using it if we're having like a lot of skin picking or hair picking, then I see some improvements there, but I'm not ever grabbing it on its own because I just haven't seen that in my clinical practice. But some of the data is pretty mixed on it. Gabapentin, it may help with withdrawal anxiety. I probably is not the first one I'm going to. I'm probably going to choose clonidine over gabapentin, but I have used it in the past. But it would probably be like a 4th or 5th line medication. But if you're choosing this as first with substances in general, especially cannabis, to kind of manage their anxiety, that's completely appropriate. The evidence does back it up. Mirtazapine, sleep and appetite. I don't typically go to mirtazapine a lot in teens and adolescents unless one population, I will grab it every time. And that's for especially our teen girls that are just simply not eating. They have this poor body image. They're restricting food. If I have cannabis on board, then I'm grabbing definitely mirtazapine with their behavioral therapy and with treating the ADHD. I'm treating all of them, but mirtazapine is the one I would typically end up using for sleep and appetite. And I would kind of not give them the clonidine then. And then at the bottom, just the kind of key take home is treating ADHD helps, but it doesn't actually treat cannabis use by itself. What it does is make patients more capable of actually engaging in the treatments that actually reduce use. So they're more likely to engage in the behavioral modification therapy, and they're actually more likely to open up and talk about it, and more likely to do the homework and exercises that's required of them. Now, case number 2, this was a very interesting case. This is one I'm still kind of actively involved in. We've made some pretty significant grounds in treatment, but still relatively difficult. This is a 17-year-old male. He had no psychiatric history, came in using daily kratom. This one is so hard because most of the time patients have no idea how much they're using. And honestly, 15 to 25 grams per day was honestly a guess just based on what they were telling me. Because I had no idea how much this kid was using. He had no idea. He actually brought in the bottle one day and it didn't even show how much was in there. Like that shows how dangerous this is. So this was a guess. I was basing it off of where this company, what products they made, what other products they were made. I ended up finding other bottles potentially that showed the grams on it. It was, so this could have been completely wrong, but that's irrelevant. It's kind of regardless from the point, but he started kratom around age 16. He used it for focus, energy, and anxiety. Especially when I hear that focus and energy, it's typically something I'm looking for them to say why they're using it is so incredibly important. But why they end up coming in, he's now reporting tolerance. He's having withdrawal whenever he tries to stop. He's having that irritability, the restlessness, the body aches, the insomnia, all the things we typically see when people come off opioids in general. He's failing classes, poor task completion, impulsivity, long-standing ADHD symptoms since childhood, never actually treated. The parents even said, "Oh, I've always known he's had ADHD," but he did fine. So, I didn't think he ever actually needed treatment. The functioning, he ended up having significant academic decline, conflict with parents, low motivation, poor executive functioning. This kid was struggling, and he incredibly smart teenager, super kind, very empathetic. he and his parents kind of described him in a completely different scenario, which really shows the conflict at home between these two. They were basically lost, had no idea what to do. This kid was like, they're controlling my life. I want to use now just to kind of prove them wrong. At one point, he even asked for ADHD treatment prior to even using kratom, and they said that that can lead to addiction, and that he was just asking to cheat the system, essentially, to try to, I think the word he uses, he said that they told me I was basically cheating in school if I ended up getting on ADHD treatment. And that's no fault to the parents. That comes to what they grew up understanding and what they grew up essentially being told. So this all comes down to just understanding what it is itself. And so with, I kind of put what the treatments are, but for lack of time here, I'm kind of explain just a little bit more. But this family did not want to treat either one of them. So I ended up suggesting Suboxone, and I suggested Vyvanse at the same time. And the dad got really upset at me and said, so we came in here to get treatment for our son, and you're going to make him more of an addict. And there was a lot of pushback on this, and I ended up having to I spent a significant amount of time. I ended up not treating him at all initially, would have him come back every week, just trying to re-educate parents on what this is. And ultimately they wanted me to start one first and then do the other. Put in this kid that would increase his risk of harm. And I couldn't even stand behind that. And typically I will kind of come up with a modified treatment plan if I need to, but this kid needed both. Because if I just treated the Suboxone, he was already increased risk of suicide because he was already having suicidal thoughts. He was really hated himself. Wasn't acute safety, so I couldn't even admit him. And he was very honest and forthcoming and was willing to engage in any treatment that I was willing to offer. And ultimately, long story short, it took about 3 weeks, and it took a lot of just teaching these parents on what the best approach was. That ultimately, if I just treated the kratom use with the Suboxone, I am drastically increasing his risk of reusing and relapse and using other substances. And if I just treat the ADHD, I'm in no way going to actually treat the actual substance use disorder. And so with him, what we ended up doing is I started Vyvanse at the same time that I started Suboxone, because I was unsure of how much we were using. I ended up starting him at 8 milligrams of Suboxone and gave them 2 milligrams as needed strips at home that patients could manage. Told them I gave them a printout of exactly what symptoms to go look for if we needed to use it as needed. Made him wait 12 hours on the dot from his last use till he started it. And then I had him come back within 24 hours of actually starting that. And we ended up getting him up to about 10 milligrams for the films that he was using. And then we started on the Vyvanse, which I got him up to about 50 milligrams quite quickly. It took me we ended up doing it over a 2.5 week period. Within 1 month, this kid had come off Suboxone completely. He had self-tapered himself back down. He was just on Vyvanse, no cravings. He truly did wonderful. I don't typically see our teens come off Suboxone on their own like he did, but he was very, very self-motivated. He was engaging. He was doing therapy 3 times a week, and he just didn't want to be on both. He had this very negative feeling he had about himself being on it, so he was able to get himself off pretty quickly. Faster than I want him to, faster than I was comfortable with. But it's been 2 months now since he has used Suboxone. So he's still high risk, but he's doing really well. So just a couple other things is, remember guys, kratom behaves like opioids. So that's what the purpose behind the Suboxone. Kind of all of our lectures support that. Remember, evidence supports treating ADHD does not worsen substance use disorder. It may actually improve engagement and outcomes. Exactly what I saw with this 17-year-old, did wonderfully. And actually remaining on treatment improves his long-term outcomes of decreased substance use later on in life. And I put this a little chart here again, to kind of go back on, but the key points I want you to take away from this is early sustained treatment is more protective than delayed or brief treatment. So if we have 2 things to treat, our substance use and our ADHD, treat both every time. Poor adherence and treatment discontinuation I can't say that. They discontinuing treatment are associated with worse outcomes. The literature does not support withholding stimulants out of fear of addiction. Treat ADHD and you actually improve executive function, engagement in therapy, and your ability to follow through. And at the very beginning, the one thing I said, and the one thing I'll continue to say is if we don't treat ADHD, these children, these adolescents will, and their version is often much riskier than ours. So that's the one thing I always want anybody to take away when it comes to the child and adolescent population. Don't give them the chance to do that. Any questions? Sorry, guys, I went about a minute over. Sorry, I kind of went through this quickly, but any questions?
Thank you. Let's see. We've got a question. How does Adderall extended release compare with Vyvanse and Concerta with abuse potential? I mainly ask because of coverage issues with Vyvanse with some insurances.
Yeah, that's definitely an issue. Most of the time, they're going to make you they're going to make you do one or the other first. I've been able to get Vyvanse approved without any prior stimulant use history, just by the substance use in general, just kind of citing that this is the lowest abuse potential. They're already abusing substances. The risk of relapse is higher, and I was able to get approved for that. Other insurances don't let me, and so I'll go to Concerta first if they need me to, but telling the parents, we just got to try this. Let me know if we have any problems with it, and usually I'll do it like a week, and then I'll switch over to right over to Vyvanse if I want to move to Vyvanse. Typically, it's not Concerta, in my opinion, just isn't going to have as much of an effect if we already have substance use on board. And so that would be considered a failed therapy. For Adderall is much more of a robust effect compared to Vyvanse. This is always one I always want to be cautious. But if that's my only option, I'm going to use it as the extended form. Never would I use Adderall for the immediate release. But if I have to use it for the extended, then I will. But typically, if it's too much or if they get more anxious, and I always ask them that kind of immediately within a couple of days. If you notice more anxiety, let me know immediately. I'm going to switch you right over to Vyvanse. But again, if those are only options, you got to use what's available to you. Just take home point is extended release, go for it. Immediate release, don't.
Let's see. There's a question. Dexedrine, is that a medication you ever prescribe?
It's not.
No.
Yeah. Not for typically what I would use. The research doesn't support it, especially for our kids and adolescents.
Great. Thank you. Well, yeah, thank you, Stephanie and Mary. We will call it there. There's a link in the chat if you want to grab the evaluation survey. Otherwise, my usual email will be coming out here in about an hour or so. So have a good Friday, and we will hope to see everyone back here in a couple weeks. Ed's doing a talk on Kratom in a couple weeks. Thanks, everybody. Have a good Friday.
Thank you.